Efficacy or addition of transcutaneous electrical stimulation to standardized physical therapy in subacute spinal spasticity, a randomized control trial. Women Department of Physical Medicine and Rehabilitation, University of Medicine, Mandalay, Myanmar. Accounts of Physical Medicine and Rehabilitation. Question and objective. Spasticity develops in an estimated 65% to 78% of the patients with spinal cord injury. Spasticity not only leads to incapacitating complications such as muscle contracture, pain, and difficulty in functional activities, but also increases the economic and caregiver burden. Suboptimal treatment of severe spasticity contributes to significant obstacles in the rehabilitation process. Therefore, the spasticity should be treated effectively and judiciously. Effective treatment of spasticity is still a therapeutic challenge because spasticity will not respond to a single therapeutic option in all individuals and necessitates a combination treatment. The neural component of spasticity will respond to dance, and the biomechanical component will respond to physical therapy. Dance, coupled with the standardized physical therapy, will be practical during SEM rehabilitation and synergistic in mechanism of action. However, there was a lack of robust evidence for antispastic effects of a combination of dance and physical therapy during the subacute SEM period. The objective of this study was to determine the immediate and short-term efficacy of the combination of the dance and standardized physical therapy in subacute spinal spasticity. Methods. In the retrospective study, the dance procedure involved two electrodes from each channel be applied to each common peroneal nerve. The symmetric biphasic rectangular waveform was used at a frequency of 100 Hz, a fluctuation of 0.2 milliseconds, and an intensity of 15 milliampere. As the primary organ measure, the composite spasticity score was used to determine the overall tonic and phases aspects of clinical spasticity. It resulted from the summation of all three subscores, the aggregate score, the Macedon score, and the aggregate score, which were designated as clinical organ measures. They were clinically assessed at baseline and immediately after the first and the last interventions for both groups. Results. For analysis for immediate effects, there was a significant reduction only in the composite spasticity score in the experimental group, p equal 0.002, but no significant reduction was observed in the control group. A significant difference was observed between the two groups, p equal 0.006. After 15 sessions of treatment, a significant reduction was determined in the composite spasticity score, p less than 0.001, the Macedon score, p equal 0.006, and the aggregate score p equal 0.003 in the experimental group, whereas none of the organ variables revealed a significant reduction in the control group. The between group difference was significant only for the composite spasticity score p equal 0.001 and the Macedon score p equal 0.005. Discussion. The mechanisms of dance in spasticity reduction is hypothesized to be mediated by modulating excessive alpha motor neuron activity through dynorphin release, and by inducing synaptic reorganization to increase efferent sensory impulse. Large fiber efferent stimulation in the palm of dance can modulate interneuronal activities through segmented and propiospinal pathways, enhancing inhibitory mechanisms such as reciprocal inhibition and respiratory synaptic inhibition. Effects of the application of dance were observed to have considerable discrepancy across the studies, partly owing to differences in stimulation parameters, treatment procedures, and organ measures used. Roughly, spasticity reduction was revealed only in high-frequency dance, but not low-frequency dance. Spasticity decrease was reported in various studies, using various pulse durations ranging from 0.1 to 0.3 milliseconds. Therefore, the pulse duration parameter seems to be less critical than the frequency parameter. Based on findings from previous studies, the 60-minute session of dance was assumed to be optimal. The duration of the present study was limited only to 3 weeks because improvement in spasticity tended to reach a plateau after 2 weeks of daily dance stimulation. Conclusion. Combination of dance with standardized physical therapy synergistically reduce clinical spasticity on both immediate and short-term basis in the subacute phase of SEM rehabilitation. However, further replication of this study with a larger sample size is required for final evidence.